do you think testosterone therapy is indicated to all women?
If you think about it, testosterone tends to decline from the early 30s. It tends to be the testosterone that falls before anything else. It's the hormone that you give someone and they go, wow, I feel so much better.
What is the age that you can start developing symptoms of perimenopause?
I would say from 35 to 40, sleep difficulties, joint pain, brain fog or clouding, a little bit of anxiety. They're just not functioning the way that they did 10 years ago. When I look at their lab panel, I find that the testosterone tends to be one of the first that drops. And that can often attribute to the fact that they don't feel quite as mentally as aware as they were previously. And they also feel that little bit fatigued.
As far as I've understood, the most effective treatment is hormone replacement therapy. What does the basic HRT look like?
Testosterone cream, an estrogen cream, and a progesterone cream that is provided at night.
What are your thoughts on using peptides?
I think that they are absolutely wonderful. GHK-Cu, the copper peptide, helps to produce collagen. Some of the others that are particularly good are helping in cellular function. Epithalon is also really good in helping to reduce the risk of aging. And it's one of the few peptides that you can actually, on a lab panel, check the benefits of it and actually see your biological age going down a little tiny bit.
Hi everyone, today's guest is Dr. Jenna Burton, a medical doctor based in Dubai, whose work spans clinical, functional, longevity, and aesthetic medicine. Her approach integrates evidence-based therapies in hormonal optimization, peptide science, exercise, nutrition, supplementation, and advanced aesthetic interventions, guided by medical expertise and objective clinical data. With over a decade in the wellness space, Dr. Burton has led occupational health initiatives, contributed to the development of medical telehealth platforms, and currently serves as the medical director at Zoe, a longevity-focused clinic combining health, aesthetics, and performance. She is board certified in aesthetic medicine, a certified personal trainer, and brings a deep understanding of both physical and emotional health into her clinical practice. And outside the clinic, she works as a ringside medic in boxing and MMA, applying her expertise in acute care to high-intensity environments. Her perspective bridges the precision of medical science with the realities of human performance and resilience. So, Jenna, does this sound about right, and did I miss something?
No, definitely didn't miss anything. Nice to see you. Thanks, Inka.
Great to see you again, and welcome to the podcast. And today I'd like to speak about aging and anti-aging and longevity, hormones, how to navigate hormonal transitions, especially as a woman, anti-aging protocols for perimenopause and menopause, those that can help to support healthy weight and weight loss, sleep, mental health, skin, and overall health, including HRT, peptides, nutrition, and exercise protocols. Sound good?
Yeah, it does, because it's just been such a huge topic recently. The whole world started talking recently about menopause and more recognition towards the perimenopause period too. So I think it's a really great topic to jump on.
Yeah, and I love that you're so excited about it. And I'm also impressed by your dedication to master so many aspects of health and help people, especially women, navigate these multiple and somewhat, I would say, complex aspects of aging, including the hormonal balance, but also physical fitness and emotional health and aesthetics. So you're a successful, hardworking medical doctor and a dedicated mother and a ringside doctor. So there where the spark came to take your medical expertise in optimizing longevity and aging, and what currently excites you the most?
Well, do you know, I sort of got frowned upon in the medical industry, to be honest, for the majority of my career, because as medics, we tend to focus, and I would say we have a very unilateral view on individuals. And I've always felt like we're people and that we should be looking at people from 360 degrees. And again, penalised very regularly in previous workplaces because I was spending far too long speaking to people, getting to know them, why is it they're getting recurrent infections, not just sort of accepting it is and giving the treatment. And I also believe that the fundamentals of medicine are kind of movement and mental health too. And that just comes from seeing people over and over and over again, whether it's in occupational health, whether it's in an air ambulance, whether it's in a general medical type clinic. So I've always said my speciality is people. And then you get into the longevity space and suddenly aesthetics, fitness or movement, emotional medicine and nutrition, etc., all comes together under the same umbrella. And it kind of felt like it was an area of medicine that was made for me because it's all my loves, and it does treat people as individuals, and it accepts that every single branch of medicine affects somebody during the process of aging. It isn't just one thing that occurs. You're looking at cellular function, you're looking at how they're moving and how they're functioning, etc. Right now, what excites me is the use of individual type treatments with peptides and genetics. So how you can actually look at somebody's genetics and see what's their risk factors. People get to understand why it is they've been craving certain things their whole life, why it is they can't sleep, and then use individual peptides and nutrition and supplementation to try and create a program for them that makes them feel good day to day. So that's the area that's, for me, I find really, really exciting and I'm passionate about.
I love that there is so much talk these days about the individualized and precision medicine, and this field is expanding. We're understanding more and more that we have these population-based data and recommendations are not applying to every single individual. And I love that you're taking the approach of actually looking in the ones all the way from the genetic levels to the individual factors. Let's talk about a little bit of aging and hormones. From a biology standpoint, okay, so I really want to discuss about this topic because from a biological standpoint, we know that, the circulating sex hormones, and I'm going into female hormones right now, but
yes,
are always in flux: estrogen, progesterone, testosterone. And then at some point we get a menopausal transition, which is followed by menopause. And I feel like if you went to school biology classes, you'd think that that was just some inevitable black box, like hormones fluctuate, then they decline, and then menopause happens, and that's it. And I find it as helpful as saying sun rises and sun sets and good luck, So to get a bit more specific, what is the foundational knowledge you wish every woman had about their hormones, including testosterone, not just for reproductive health, but for aging, for metabolic function, and for longevity? The less talked about fundamentals we miss because maybe there is a gap right now in general practice or education.
I mean, the thing is, there is just so many things that I wish everybody knew day to day. So historically, in clinical medicine, we're taught wait for your symptoms to occur. And symptoms are usually described as sleep problems, night sweats. And nowadays, people are starting to come up with, okay, we recognize that there's a mental health component as well, potentially to menopause. And they usually think about anxiety. But our sex hormones are part of almost every single bodily function that goes on. So, for instance, the hippocampus, which is responsible for memory, is driven by testosterone and estrogen. So as we start to decline in estrogen and testosterone, we lose our ability to make new memories as well, and we become forgetful. It's why people can walk into a room and think, hang on, what am I here for, etc. We forget that it plays a huge part on mood. So not just about anxiety. Progesterone calms us, testosterone and estrogen help to elevate mood. So it's also really important for our mental health that we do have the hormones that we're meant to have. Likewise, and I have really done quite sort of a big campaign to talk about the collagen effects that occur during menopause. Estrogen is hugely responsible for helping us to proliferate new collagen, and it also helps in our regulation of downgrading collagen. So without enough estrogen, not only are we not producing enough collagen, but we're also downregulating it quicker. And therefore, collagen is fundamental for our bone health, our joints, our bowels, our skin, our hair as well. But it's part of the sort of fiber mesh of our entire body. So it's hugely fundamental. It's the most abundant protein you get in your body. And within the first 5 years of menopause, we lose about 30% of our collagen. Our sex hormones, as well as they drop, they exponentially increase the rate of aging, and we tend to increase the aging of our cellular function by 6% as we go through transition through menopause. We forget about our skeletal system, although there is a little bit more of a push for education around that in sort of more recent years. But estrogen, again, is hugely fundamental for our skeletal system. And we forget that osteoporosis has an impact on wedge fractures, causing us to become more humped on our face. As we lose bone density, our faces tend to slump. It has an aesthetic purpose. We can also get fractures of our ribs if we're osteoporotic, which can mean that high intensity coughs even can lead to fractures, which have implications such as pain.
Oh.
If we fracture our hip, there is a 50% risk of mortality within the first year as we age. So these are not just things where we think, oh, we might be more inclined to break our wrist. It's much greater and wider than that. So I think the message I want to get across to people is just how fundamentally important our hormones are. And like I say, traditionally, we're taught wait for symptoms. And I want to say, I don't necessarily think that's the right approach. I think we should be monitoring, looking at the data to see where our hormones are at, and then having a balanced debate to decide, would I benefit more from hormones or would I benefit more from waiting before I replace?
That's an excellent approach for it. And I believe, like in many healthcare settings, GPs don't routinely offer female hormone testing. And even sometimes when you have clear clinical indications when you should be tested, it's still somewhat less comprehensive that it could be the panel. So if someone wants to take a more proactive, self-directed approach, what would your baseline hormone panel look like? Would it be relatively straightforward, basic female hormones, or would you include something more comprehensive such as hormone metabolites via Dutch or even ovarian reserve assessment?
So if I was looking at somebody's hormones to look at hormone replacement therapy, I would always recommend the Dutch test, which, as you alluded to, it looks at the metabolites of our hormones. And it kind of looks, it preferentializes, well, hang on, can I see a little bit more E2, which is the most dominant female hormone that you would get sort of prior to menopause? Or is there a little bit more E1 or E3, which are less potent, for instance, and tend to get more sort of in the peri to post-menopause period? Likewise, I would also consider cycle mapping, because when we're thinking about, is somebody going through hormonal changes as part of the menopause, what you see is that their hormones fluctuate a lot more than they would usually. And you can get erratic raises in estrogen, for instance, or you can get some FSH, LH that rise very, very quickly, and then they come down again quite just as quickly. And that's not common for somebody that is going through sort of a very balanced cyclical hormonal cycle. So what I would do is, 1, test more, 2, look at doing urine tests. If somebody didn't have the financial reserve available to say, right, I'm going to jump into Dutch tests, which are a little bit more expensive, I'd say, look, do a blood panel. I would include DHEA, which tends to drop a little bit more. It's a precursor to all the sex hormones. It's one of the first markers that tends to drop in when we're looking at sort of the perimenopause period. I would look at your estrogens, your progesterone. I'd look at your sex hormone binding globulin, which also tends to decrease quite early on in the menopause. So that means that your free testosterone would remain about the same, but your total testosterone would be a little bit reduced. But the sex hormone binding globulin that's mopping up some of that testosterone would also be a little bit less. So the free remains the same, but the total is less. I would also suggest looking at FSH, LH, which are obviously what stimulates our eggs to be released. And I would also then as well, I'd consider looking at thyroid function too, because sometimes there is kind of an interlink, and you can see that occasionally thyroid function can tend to go off a little bit around the same time. And also to remember some of the basics when we're looking at symptoms of menopause. You have to pinpoint that it's menopause. It's not anemia that's causing tiredness. It's not thyroid dysfunction that's causing it. It's not a mineral deficiency that's causing it. So it's quite a good idea to do those wider panels, maybe every 3 to 6 months. And then the more sort of owned in ones that are more specific to hormones, maybe on a slightly more regular basis, potentially 4 times within a month cycle.
And when should females start measuring their hormones, and how often should they measure?
That depends so much on the person. So if they're having symptoms, you might consider doing it from a younger age. If they're not, then I would say when you kind of get sort of late 30s, 40s, that's kind of the time that you're going to want to start checking. Now, there are some people that would rather leave it be until they're about 45, and there's nothing wrong with that. It's less proactive in nature. However, the chances of them having any significant long-term effects in sort of the very early stages of the perimenopause are very low. So there's nothing wrong with taking that approach. It depends on people's time resource, their financial resource, and also on their symptom levels. There is no hard date. With regards to protocols, my protocol is from 40 onwards. I do recommend doing at least yearly checks. If they're symptomatic or they're concerned, you do it more regularly.
Yeah, so many women in their 30s assume that they are too young for hormone decline or perimenopause symptoms. Clinically, what have you seen? What are the earliest patterns or ages you see women in their maybe mid to late 30s? Or like, what is the age that you can start developing symptoms of perimenopause?
I mean, it depends genetically on what you're predisposed to. So there are some people that go through the menopause even in the late 30s, which is terribly sad because it has a fertility component and it has a long-term health component as well. But everyone is that little bit different. I would say from 35 to 40, that's when people tend to start getting quite gradual symptoms of sleep difficulties, less so joint pain, less so brain fog or clouding, but people can start to get a little bit of anxiety. People might start to feel that they're just not functioning the way that they did 10 years ago. That would be the most common thing that people tell me. When I look at their lab panel, I find that the testosterone tends to be one of the first that drops. And that can often attribute to the fact that they don't feel quite as mentally as aware as they were previously. And they also feel that little bit fatigued. Often as well, a lot of people around that age bracket, they're still on the oral contraceptive pill, which is a whole other debate in its own right. But that also drives down testosterone too, and it can mask the symptoms of the perimenopausal period.
All right. So to summarize, and please correct if I got this wrong, but what I understood is that you'd want to look at symptoms like sleep issues, first of all, mental health symptoms, especially anxiety, and maybe reduced drive and motivation. And if this sounds familiar, then it's worth checking your hormones to see if it might be related to hormonal decline. Not to say that it is necessarily, but just to go and have a check if you want that kind of mental peace with that.
I would say that for anybody that's having any mental health type symptoms, you should go and speak to your doctor anyway. And the hormonal section will be one part of the assessment. And obviously age, genetic predisposition, lifestyle will have an impact too. You can't change the dates that you're going to go through menopause per se. You can't delay it. But what you can do is try and prevent accelerated onset of menopause. And it might be if somebody has had a high sugar diet, they have had a lifestyle that has led to a lot of free radicals in the body. If they have been subject to lots of toxins, they haven't moved themselves very much. They've basically had sort of poor day-to-day style activities. Likewise, if they've been very underweight and they've been subject to low estrogen for a prolonged period of times, you might find that the hormonal piece is something you think about a bit more readily, because it might be that they have had an accelerated onset of their menopause. One of the other ways that you would also look on a lab panel to say, okay, maybe this mental health issue could be related to your hormones as opposed to anything else, is you'd also have a look at inhibin B and also anti-Müllerian hormone. Anti-Müllerian hormone looks at your egg reserve, and it's quite a good indicator as to sort of how long is it that you was still having a monthly cycle. And the inhibin B is one of the first things that tends to sort of drop a little bit. So those are two other sort of panels that are individual blood markers that you could put in that might sort of steer you towards thinking that the mental health was due to that as opposed to something else. But you can't just do one thing in isolation. Mental health is one of those things that you have to take a broad history, and sometimes you have to do sort of a rather broad lab panel to kind of distinguish, is it this or is it that?
Yeah, absolutely, absolutely. And going into also the history and your nervous system functioning and traumas
Absolutely.
and everything. Mental health is what I find, as a also having a degree in neuropsychology, is that mental health is, it's like a syndromes, and the syndromes of anxiety or depression can be related to so many root causes. That is one of the symptomologies that needs the most comprehensive of assessment, and it's often reduced into mental health testing, and it's often medicated based on the symptoms, not the root causes, which is quite sad. But I love that there are doctors like you who understand the delicacies of how mental health are related to the physiology as well, and how comprehensive approach we need to take with that.
It really is. I like to dub it emotional medicine because so much of the way that we process emotions and our ability to process emotions will affect how we feel. And obviously, we're talking now about longevity and hormone replacement. But if somebody isn't processing particularly well, which you usually get through a detailed history, so we've talked about lab panels, there are some lab panels that will not be able to identify this. But if someone is carrying around a lot of unregulated emotional sort of matter, it doesn't matter how much estrogen, testosterone, etc. that you give, you are not going to make that problem go away, which is why it is a slight nuance within the medical space where we say, okay, yes, hormones can drive mental health. Mental health in some ways can affect hormones, but if there is another issue that is there, that has got to be identified and addressed in its own right.
Yeah, absolutely. Let's discuss hormonal balance, although I've noticed these days this term can trigger someone.
Yes.
So say the relative balance of circulating hormones, including steroid hormones, peptide hormones, and such. So as far as I've understood, the most effective treatment at the moment we kind of know is for especially postmenopausal women is hormone replacement therapy. And today there's recently been a lot of discussion about the initiation age of the treatment. So the literature seems to suggest that it can be beneficial for women within 10 years of menopause. If I understood correctly, within the onset of menopause, you have up to 10 years to start HRT for the best effects and reduced risk profile. What's your perspective or thoughts on initiating estrogen therapy in perimenopause or menopause? Do we need to take proactive approach with it? And what does the basic HRT look like? And where does testosterone therapy fit into that picture? Because now it's also having a recent surge in popularity, or at least in discussion.
You know, you said it perfectly. These things and these discussions can trigger people because you have medics that sit on two sides of a very, very different fence. So what we are taught traditionally in medicine is that ideally to look at the cost-benefit ratio of taking hormone replacement therapy, it should be used within 10 years of the cessation of periods, so when your periods end, and before the age of 60. And that's what we traditionally say. And then as time goes on, it becomes a balance of what is the cardiovascular risk of taking HRT, because estrogens can predispose to blood clots, but that tends to be oral estrogens, and blood clots can cause DVTs, pulmonary embolisms, and sort of more severely strokes and also heart attacks, etc. And it can also increase the risk of breast cancer and endometrial cancer. So it becomes each year you'd have a chat with your doctor about, is the benefit to risk worth it, to be honest. Likewise, we wait for symptoms before we treat. Now, my general protocol is that when somebody comes in and we see a few repeated markers of things being low, I replace it and see how they feel. And most commonly, people tend to feel better. It's very, 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 very rare that people don't feel better. And often people have actually been thirsty for quite a while for a little bit of hormone replacement, but just not realised. Now, if somebody is in their late 30s and we were looking at jumping in with sort of quite high hormonal therapies, that would not be the right thing, because don't forget, they're still going to be getting estrogen spikes, and you can make someone feel really rather dreadful if you give them far too much estrogen and far too much progesterone, especially. The progesterone will make people feel really fatigued, and the estrogen can cause some weight gain, etc. Likewise, too much testosterone can cause acne and maybe even some mild hair growth, not things that people are going to want. So what I suggest, when people start to feel fatigued or just not quite right, we test. Ideally, we would also do a repeated 2 or 3 tests. If we haven't got the luxury of time, or people are really feeling rather dreadful, or their markers are just so out of whack, we start with a low dose therapy. And it would depend on what the markers are to depend on what it is that we give. A typical therapy with 3 different hormones would look at a testosterone cream that was applied in the morning, and an estrogen cream that was provided in the morning, and a progesterone cream that is provided at night. And that would be quite a typical type of therapy. There are some people that would rather use the Mirena coil in order to get their sort of progesterone. And it would tend to be, if they're still having cycles, 2 weeks on of progesterone, 2 weeks off. If they're not having cycles at all, then you sort of recommend that about 25 out of 30 days, you would take the triple therapy. But it really is quite difficult to say when exactly. I tend to sit and talk to people and gauge what is going on in their body to decide what is the exact date. But I would say it's usually around early to mid 40s for most people that I tend to treat. And we start slow and we build up until we get a steady level, and then we just keep them at that unless anything changes.
Right. And do you think testosterone therapy is indicated to all women? Because, for example, here in the Nordics, it's not, at least in Finland, it's not a standard of care to initiate testosterone, but HRT is common.
Yeah, I'd say that in the UK, we're starting to prescribe testosterone a lot more than we used to. And if you think about it, testosterone tends to decline from the early 30s. So, and like I mentioned, if I look at women's testosterone, it tends to be the testosterone that falls before anything else. And actually, I have to say, this is subjective now, but when I see patients, I would say that when you give testosterone to women, they tend to get the most. It's the hormone that you give someone and they go, wow, I feel so much better. So I would say that from a subjectivity perspective, people tend to feel a lot better when they are given testosterone. It doesn't mean it needs to form a standard protocol. I'd say it forms part of my standard protocol because I see the benefits. Now, again, we're not talking about giving people super high doses. The testosterone dose for a woman is very low, and it's very important that we get the androgen to estrogen index correct. So it is something that needs to be monitored. So it's not like we say, there you go, there's some testosterone, off you go. It's like, okay, at least every 6 months, we're going to check in with your ratios and check that things are still right. We don't want to androgenize you. We want you to feel good and to be running at your optimal. So they're not super physiological levels. We're just putting people back to where physiology had them 10 years before.
Right, that makes sense. And I guess for the listeners who are not that familiar with the ratios of female hormones or hormones circulating in the female body, it's good to acknowledge that testosterone is our dominating hormone. We have relatively more testosterone than estrogen, but of course a lot less than male body has. But it's still a quite significant contributor of our motivation, drive, and energy.
Absolutely. It has been a very underrated female hormone. And actually, you asked me when we opened this podcast, what were some of the misconceptions around hormones? And that is that women have estrogen and progesterone and men have testosterone. Men have estrogen, progesterone, and testosterone. And likewise, we have all same 3 too, but just in different ratios.
I know that you're a big fan of peptides, and I'd like to know about this. So I recently had Ryan Smith in the podcast, a well-respected peptide expert and the founder of TaylorMade Compounding, the company that basically brought most of the peptides into the US market. And that podcast was wildly popular. What are your thoughts on using peptides to support female hormones and or the aging process and the symptoms of hormonal decline and aging itself?
Well, my friends tell me that I'm always harping on about peptides. So I would say I'm probably going to be a supporter, is going to be the answer to this question. And you also asked earlier, how do I sort of see my passion sort of developing, and peptides is very, very much at the core of that. And I think a lot of what we're doing now with medicines, with creams, etc., are going to be used through peptides, but maybe through different routes. So peptides are short chain amino acids, and they're usually given in sort of a subdermal fashion. So you'd give it subcutaneously, small injection to the skin. There are lots and lots of research that is going on at the moment to try and make peptides more accessible through sprays and creams with equal efficacy. And I think as that develops, that's going to be really quite exciting. Now, how do I feel about using them? You can't use them for everything. So they're not going to replace hormone replacement therapy, I don't believe, or at least we haven't got the peptides available yet to do so. Who knows in 10 years' time? But I think that they are absolutely wonderful in helping two main components. So one is collagen. So I told you we lose about 30% of collagen in the first 5 years of menopause, and it is fundamental to how we function as human beings. And obviously women, as we age, we worry so much about how we look. Men, I find, tend to worry more about performance. But collagen is it's needed for everything. And GHK-Cu, the copper peptide, helps to produce collagen. Now, you can't produce collagen unless you have the building blocks to make the collagen. So you need to have the protein in your bloodstream available to actually make collagen. So the combination of a high protein diet with GHK-Cu, I think, is absolutely fantastic. And it tends to be 6-week cycles. So it's 6 weeks on, 6 weeks off, 6 weeks on, 6 weeks off. That tends to be a sort of a typical type of protocol I put clients on. And there are a few people that do get some localized skin reactions to the copper, so it's not for everybody. But for those that tolerate it, and the majority tolerate it very well, there is not really too many downsides, if any at all, to using copper peptide.
What about copper peptide topically?
It's only a localized reaction. So if you're going to apply copper peptide to the hair, it will help with hair growth. If you apply it to the skin, it's going to help with the quality of your skin. It's not going to work from the inside out. It's just going to work where it's applied. So it doesn't tend to have the full body benefits that you would get from using it subcutaneously. And the dosing is usually quite a lot lower. It's very successful for men that are losing their hair. And I have a number of gentlemen on a repeat prescription of their copper dropper. And it's not particularly cheap, but it works very well. And I know that as soon as it goes, they start saying, I feel like my hair's going again. I feel like my hair's going again. So I think it has its place. Personally, if you can tolerate it, I prefer subcutaneously. If you can't, then we opt for topical use.
Right.
Some of the others that are particularly good are helping in cellular function. I mentioned that we increase the rate of aging in our cells by about 6% sort of through the menopause. So if you can help to hold on to cellular function, and you can do that with a peptide called Mots-c. We usually use it about twice a year. That's really good for helping with lipid metabolism, also with glucose metabolism, and also in the way that our mitochondria function. So I'm a big supporter of it. The sad thing is with Mots-c, people don't tend to feel too much in their body when they use it. But yet the research is there to show that how beneficial it is to the cells and to the aging of the cells. And plus, like I say, it's only a twice a year type of thing. Epithalon is also really good in helping to reduce the risk of aging, which occurs, as I say, at an accelerated rate through menopause. And epithalon actually increases the length of our telomeres, so it actually helps to reduce our biological age, and successfully to do that as well. And it's one of the few peptides that you can actually, on a lab panel, check the benefits of it. You can sort of do a true age test about 6 months after you've used the epithalon and actually see your biological age going down a little tiny bit. So it's quite an exciting peptide. Now, the other thing that we haven't really talked about is some of the body changes that occur during menopause, such as fat distribution. So as our estrogen declines, what we tend to do as women is we store our fatty tissue more in our breasts and our stomach, as opposed to our hips and our bottoms. And obviously that's not what people really want. And it also tends to cause more visceral fat. So there are other peptides that can help to shave off a little bit of that fatty tissue. Now, none of these are in replacement of hormone replacement therapy. They're adjuncts to that therapy. And there are things that like AOD 9604, it's sort of quite cutely referred to as the Barbie peptide in the States. because it helps to metabolize fat around the truncal region in a similar way that growth hormone would, but without the growth hormone side effects. Or you can actually use a growth hormone releasing peptide that will actually help with body composition as well, especially if you're engaging in strength training. So they're my main go-tos, to be honest. There are obviously some people that their visceral fat is so high that we can consider something a little bit more extreme, maybe a GLP-1 agonist, etc. But that's not for everyone, and that is on a case-by-case benefit.
All right, that was a great overview, and I would encourage the listeners, if you want to learn more about these specific peptides, to go and listen also the Ryan Smith's podcast where we covered some of these. But I would really love to also hear from your perspective, because you're also a certified personal trainer. I know exercise is a big part of your own daily protocol. And one of the most Googled questions is exercise for menopause. So I know everyone's talking about resistance training, but I went to look into the research. There were also a lot of benefits about aerobic exercise. And there was a recent meta-analysis of 61 randomized controlled trials, finding that regular aerobic exercise, actually in this case, lowered blood pressure, LDL, triglycerides, raised HDL, and improved anxiety. Clearly, exercise is central both for the physiological and psychological aspects of this transition. From your expertise, is there an optimal way to train in, say, pre or peri or post-menopause? And does that strategy shift based on hormonal changes?
So first of all, there is no bad form of exercise. Movement is movement. What you can do is exercise to the absolute extreme, and it can then increase sort of a little bit of cortisol to the extreme, and that can have a sort of knock-on effect on immune system, etc. But that is rare with the day-to-day Joe blogs that's just looking to train. Now, I'm a big believer in having a varied exercise protocol, and my words to my clients usually are, look, get your 2 days of resistance training in, and that means touching each body part twice in a week. Everything else is free. So if you're doing a circuit class, a run, whatever it may be, a cardiovascular exercise will help with your mental health. It will help to burn little bits of fat, which will help to reduce your LDL, which is shown to be higher in menopause. Likewise, HDL is also shown to be a little bit lower. So that's the fats that can affect the cardiovascular system negatively versus the fats that affect the cardiovascular system positively. So just have fun with your exercise and do whatever you're going to stick to. So whatever is sustainable is the most important thing. So, for instance, you sort of said earlier, I am a mum of 3 young children. For me, I know what exercise I can get in. And so I tend to, what they call exercise snacking. So I rarely exercise for more than half an hour. And I get in and I have quite a blasted workout and I finish because I know it's something that I can stick with. Do whatever is going to be manageable. Now, there is a lot of research to suggest that strength training, and by strength, I also mean high intensity strength training, so not necessarily hypertrophy type training, which is in the 8 to 12 type rep range, but actually slightly slower rep ranges, so maybe anything between 3 to 6 to 8 reps, can actually be particularly beneficial around the peri to post menopause, because it helps with the density of muscle fibers. The ability to actually create or inflate muscles gets harder as we go through menopause. So it's really important that we start concentrating on those muscle fibers and making them as dense as possible. However, there is also an increased risk of that, especially if somebody has never trained before, which is why I'm a big believer in, start training as early as you can, learn how to do it safely with a personal trainer. So then you can start to increase your strength that little bit higher without actually having the risk of injury. Everybody is a little bit different as to what they enjoy. If somebody's not going to enjoy doing sort of max reps, then maybe you'd say, okay, well, look, let's see what we can do safely that you're going to stick to. But if you are doing aerobic type activity, you're still going to be using your muscles. Likewise, if you're using your muscles effectively in resistance training, you're still going to be having some aerobic impact as well.
Yeah. So combine both types of exercise, do preferably 2 sessions of resistance, and do what you can with the aerobic as well, and enjoy your exercise. Like do what feels good, right?
I mean, it depends on the individual. There are some people that want to look at increasing their VO2 max. And if that's the case, and that is linked with improved markers for longevity, then you're going to be looking at doing 4-minute high intensity aerobic type activity. And that is going to be optimal to have with your strength training of around sort of 5-6 repetitions, at sort of at a rate of perceived exertion of around 7 to 8. So, there are ways of making it more advanced. Do check in with your twice a week resistance training, and then do what's going to be enjoyable, but at least keep about 4 sessions of exercise a week at the very minimum, so that you can get those cardiovascular benefits along with the benefits to your skeletal system, your muscle mass, and keeping that basal metabolic rate high.
Thank you. So I know today we have a time limitation. I still had questions for you, but maybe we need to do another. I would actually love to have you back and discuss more in detail about like nutrition, supplements, everything else related to menopausal transition and menopause and female health as well. But for today, for the last questions, from clinical perspective, what is the smartest starting point in your view? So for someone entering to these hormonal shifts or realizing that, okay, I'm experiencing this, but I feel a bit overwhelmed of all of the options that I can do or should do, what is a starting point at the first steps to get the most significant improvements early on?
When you say what is the starting point, would that be for their diagnostics, or do you want the starting point for what they can do proactively from home?
Well, let's say they've already realized their hormones are low or tested and noticed hormones are low. So how to go about with it? If you are not having dedicated and well-aware physician like yourself to guide you, what you can do at home.
So first of all, hormones are made from proteins, and we talked before about the benefits of protein, and I can't stress that enough, how important that is, especially around this time, because you need the building blocks. You can't tell the body to make stuff if you haven't got it there in order to make. So I would be prioritizing my protein intake for sure. I would also be taking a wide variety of supplements. Now, there's a lot of supplements on the market, like primrose oil, etc., that are for menopause. Now, the best way of supporting this phase of life is actually just to have all the minerals and the vitamins that you need specifically. So not to focus on what's right for menopause, but to focus on what's right for you as an individual. And that is actually going to soothe some of the symptoms more so than a menopause type supplement. The use of DHEA is controversial because there are studies that show DHEA, which is your precursor to all the sex hormones, will help boost your estrogen, testosterone, etc. But likewise, there are lots of studies that show that it doesn't. I always say, look, it's not a bad starting point to see how you feel after taking it and to see if things shift a little bit. And then I would say, if you want to get on the journey of using menopause, do some research at home. So before you say, right, I'm ready for HRT, each practitioner will have a different style of prescribing. I tend to use bioidentical hormones. I have very trusted medical colleagues that will not touch bioidentical hormone replacement therapies, and they have their reasons as to why. So I would say find out what's right for you. There's a wonderful lady in the UK called the Menopause Doctor, and she has a whole web page. I think her name is Louise Newson, and she has a whole web page full of great research articles comparing different types of hormone therapies, telling you when is a good time to start, what are the risks of each one. Get yourself equipped with the information so that you go to your physician ready to say, I'm ready and I would like to start this. Now, they will then tweak that for you, but it'd be great if you already knew what it is that you're looking for, because you don't want it to be practitioner dependent. I think it should come from the individual, and the practitioner helps facilitate you on that journey.
I love that. Take ownership of your own health journey.
The information is out there for people. And like I say, it's such a controversial topic. What I normally do with my clients, patients, whatever you want to call them, because that is also a triggering topic, is I say to people, this is what I think you should do. I'm going to send you some information. Do your research, see what fits right for you and your lifestyle.
Yeah. Jenna, thank you so much for the time and your expertise today. Your ability to connect the underlying biology with practical evidence-based strategies is incredibly valuable. And before we close, for people who want to learn more, especially from you, could you provide your social links where people can, I know you're active on Instagram, for example, so the people can go and follow you?
Yes, I'm at Dr. Jenna Burton, and I also have a website called www.drjennaburton.net.